Hi, everybody. Harvey L. with 93.7 FM, the People Station. I'm broadcasting today from the Medical University of South Carolina, and I've got Dr. Mark Katz. He's a cardiologist, and we're going to talk today about his career, his life, and we're also going to talk about some of the new innovative things that are going on as it relates to heart medicine. Welcome to New Perspectives.
Thanks. Glad to be here.
Tell us about your life, your career. Where did you start? Where did you go to school, and that kind of stuff, if you will.
I grew up in New York, went to medical school in New Orleans at Tulane Medical School. Then I did my residency and training in Richmond, Virginia. I was lucky enough to train with Richard Lauer, who was one of the people who developed heart transplants, and was in practice there for many years. And had an opportunity to move to Medical University of South Carolina this past December. And I've been really excited to be here since. And I'm actually a cardiac surgeon.
Okay. What made you go into becoming a heart surgeon? What was that made the decision for you?
I went to medical school thinking I wanted to do family practice. And I'm about as far away from that as you can get. And so I was watching some of the things that were being done in cardiac surgery as a student at Tulane in New Orleans. And it really, really piqued my interest.
Did you travel at all? Did you go outside the country?
I've traveled quite a bit associated with my work. And in fact, when we were first learning about using the robotic system for heart surgery, I was in Europe on September 11th, 2001. Wow. And consequently ended up spending some extra time there working with the robot because we couldn't get back. So since then, I've been to Singapore teaching robotic heart surgery. I've been to Austria, been to a variety of places around the country, helping others learn, and learning from others, obviously. So it's been a great experience. Yeah.
So heart transplants, have you done any of those at all?
Over 200.
Over 200 transplants. Wow. Heart condition or heart disease, number one leading killer in this country. Am I right?
It is. It continues to be and has been for a long time, and unless we make some radical changes in our diet, it will continue to be that way.
What are the primary, let's talk to the audience, if you will. Tell us some of the primary dietary concerns. Let's talk about those, if you will.
So everyone knows about cholesterol, hardening of the arteries. Mm-hmm. There is some controversy, but we all know that your weight, your sugar intake, fat intake, all those are big factors in what happens. So a lot of people that feel that the safest diet from the standpoint of your heart is really a diet that contains no meat, a low-fat vegan diet. There's evidence that shows that you can even reverse coronary disease with that.
Well, we know that Bill Clinton had, we'll talk about stents in a moment, but we understand Bill Clinton had some stents implanted to help him with his coronary heart disease. And then they got blocked. Is that because he didn't change his diet, he says, and then, of course, later on he had to change it and become more of a vegan. Is that basically what you're explaining?
Well, he ended up having coronary bypass surgery, and he did change his diet and went on a low-fat vegan diet and lost quite a bit of weight. And that's realistically, when you think about it, it's your metabolism that makes blockages develop, and the fuel that you put in your body has a lot to do with the metabolism.
In other words, the food may not metabolize quickly, may not digest quickly, you may not exercise enough.
So exercise isn't important. The rate of metabolism isn't as much the issue as the type of fuel that you're giving your body and then what the byproducts are. Clearly, diet is a tremendous part of it. And as we were mentioning earlier, it's the fuel that you give your body as far as what byproducts your body makes and how that ends up.
Tell us about your diet, if you will, really quickly. You want to give it?
My diet was great until I moved to Charleston, and I've been eating my way through the city. But I was on a low-fat vegan diet for over 6.5 years, and I cut my cholesterol in half and lost quite a bit of weight. Now I've put some of it back since I've been here, and I need to get back on the wagon.
Do you do much juices? Do you have a?
I have a Vitamix, and I do juices, and make different kinds of smoothies. Sure, but I mean the biggest thing really is being rational in how you do things, and you don't have to go to one extreme or the other. And most people know the things that they should be doing. Unfortunately, they get bombarded with advertisement every step of the way in their lives about the wrong things to do. But exercise and diet, it's the key. People make vast sums of money writing diet books. No one will ever buy my diet book because my diet book is to eat right and exercise more, and it would fit on one page. Right?
Now let's talk about some of the remedies, I guess, is what we want to try to get to.
Sure. So I was fortunate enough to have the third surgical robot in the country back in 2001. And been working with it since then. Was part of the initial trial that led to its approval by the FDA.
You say robot. Give us the background. Is the robot inside the body? Is it outside the body? Or
The Da Vinci robotic system, and it's outside, and it's a very powerful computer interface between the surgeon and the patient, and it allows us to operate through tiny little ports. And when I say tiny ports, traditional open heart surgery is done by splitting the breastbone, an incision from the base of the neck to the top of the abdomen, that long across the whole chest, and then going through a bone. Using a system like this robotic system, we can go in through a series of little half-inch incisions between the ribs, so no bones, just going through the muscle, and that translates what my hands do into these instruments that go inside the heart and do it. So I can, sitting in a console across the room, manipulating the instruments that we put in through ports into the chest. It also magnifies things. So the scope, which is 3D vision, because there's two cameras in the scope, and it magnifies things 10 to 15 times. So the main thing that I've used it for is people who have leaky valves.
Okay. Explain what a leaky valve is.
So mainly the mitral valve is what the best utilization of this technology is for. And the mitral valve is the main valve between the left atrium, where the blood comes after it's been through the lungs, has oxygen put in, and then on its way into the ventricle, the main pumping chamber that pumps the blood out to your brain and the rest of your body.
Tell us some of the symptoms that people would have normally that would require this.
So when that valve leaks, as the heart squeezes, it's supposed to close. But if it leaks, a lot of the blood goes back towards the lungs and puts pressure, doesn't let the blood come out of the lungs, so people get short of breath. It usually starts when it's in its mild phases, just with heavy exertion. Right. And then as it progresses and the leak becomes more and the pressure back towards the lungs becomes higher, it can go on to with minimal activities or even develop into heart failure.
Now, there is something called a flash pulmonary edema. Is it something similar to that?
So pulmonary edema is fluid in the lungs, and that is part of heart failure. And so, yes, that's definitely related to what people can see. But they get short of breath. It can lead to enlargement of the heart, especially the atrium, and that leads to atrial fibrillation and irregular heart rhythm that can cause strokes.
So, in other words, it's a downward spiral. If this is not corrected early on, then the heart enlarges, and there are other symptoms and other things that go on, and then eventually morbidity, because the people are not living up to what they need to do, or they're not seeing a cardiologist who's as smart as you are, I guess.
Exactly. It used to be that me, as a heart surgeon, would not see patients with leaking valves like this until they had heart failure. And the guidelines have actually changed over the last number of years. And since we've learned new techniques to repair valves instead of replacing them, now if someone has moderately severe or severe leakage of that valve, even if they don't have symptoms, the guidelines state that they should speak to someone who's experienced in valve repair.
Which is who you are.
Exactly.
Now here's a question. When you say valve repair, how do you repair it? Is there a device that goes in? Is there, tell us about that if you will.
Sure. So the mitral valve has two leaflets, and they're supported by these cords. They're like strings on a parachute that are connected to the inside of the heart. What happens frequently is those cords will stretch out or rupture. So instead of the leaflets coming together and forming a good seal, one of them would flip up and not seal with the other. And so what we do is we go in and we replace those cords, resuspend that area of the valve, and the other thing that happens is the whole circumference of the valve tends to stretch out and pull the leaflets apart. So in addition to putting new cords in to support the leaflets, we put a ring around the valve that decreases their circumference and brings those leaflets back together so they seal.
What are the cords made of that you use to replace?
Gore-Tex. Use Gore-Tex suture to replace them. And Gore-Tex is very good because it's a very strong suture. It's easy to manipulate and to use to get it into the position that you want.
How many of these procedures have we been doing? What's the impact thus far? Is it still in the trial stage, or have we gotten beyond that? Tell us where we're at with that.
So the real impact of doing the surgery this way is patient recovery. Instead of splitting the breastbone, and when we do that, the patients are in the hospital on average a week.
Once upon a time, it was 2 weeks recovery, or a week, at least a week. And I've seen people who've had open heart surgery, and sometimes they had to rest for at least a month.
When we do this procedure minimally invasively using the robotic system, patients go home in 2 days, and they can get back to their full activities as soon as they feel up to it, most within a week or so. And then 3 months of restricted activities. So if you have a job where you have to do heavy physical labor, you're out of work for 3 months with traditional open heart surgery, whereas if we do it this way, I've had patients go back to work in as little as 4 days. Now, that's pushing it a little bit, but it's usually within a week or two that they can get back to their full activity. So that has a huge impact on people's lives. Plus, because I'm operating with a scope that's actually inside the heart, I can see the valve structures better. And I'm doing better repairs now than I did when I was doing them open.
Because you've matured and it's evolved and it's gotten better and you've gotten better.
And this valve is deep down inside the heart. So by being able to put a scope right there, it's better than I could see through traditional surgery.
While you're in there, are there other things that you're also able to see because of this robotics?
Sure. I mean, there are other procedures I do with the robotic system as well. Mitral valve repair is the most common thing, but we've repaired the tricuspid valve, another one of the heart valves, fixed holes in people's hearts, have done some ablations for rhythm problems like atrial fibrillation.
Holes in the hearts are actually inside the heart. They're not from the outside. They're actually on the inside, because people say, I got a hole in my heart. Sometimes people think that it's a hole all the way through the heart, but it's actually inside the heart. What is that exactly, if you don't mind telling us?
The common one that we deal with in this is called an atrial septal defect, and it's a hole between the atria, the two upper chambers of the heart. It's a hole that everyone is born with, and they close usually in babies when they're born, but in some people they progress and stay open. So those are things that we've been able to close with that. But again, the most common thing is the mitral valve, leaky mitral valve. It's the most common valve problem in the country. It affects about 3 to 5% of the population, so about 9 million people across the United States, about 150,000 people in South Carolina. And not everyone needs surgery. If it's in its mild stages, it's something that can just be, followed by their primary care physician or their cardiologist. But as it starts to leak more, that's when you want to be able to fix it before it causes enlargement of the heart or irregular heart rhythms or heart failure. It used to be that people would see their primary care doctor, and you might hear a heart rhythm and ask a heart murmur and ask them how they're doing, and they'd say fine, and he'd say, okay, great, see you next year. Now it's important that they get an echocardiogram, which is, an ultrasound picture of the heart, because even if they're feeling well, our bodies do a great job of compensating sometimes. And the echo can show if there's progression in whatever it is that's causing that murmur, whether it be a narrowing of the aortic valve or a leaky mitral valve, which are the two most common. And again, even though they may not have symptoms, if they've got a high degree of leakage in that valve, they want to talk to someone about getting it repaired before it causes problems. So I've been doing these robotic mitral valve repairs since 2001, since I had one of the early robotic systems, and built up a strong practice in Virginia doing it. Now, since I've moved here to Charleston, we've just started our program here last month. So it's exciting because all of the infrastructure has been here. So for us to get a program like this started here was really very simple, because the nursing staff has been wonderful, the facilities are wonderful, the ICU is wonderful, cardiac anesthesia, everything was in place. We're just bringing a new procedure.
Giving back and teaching, training. You also have students, I'm sure, that you're training that are working, watching you and under your tutelage.
We do have residents and students, and using this robotic system is actually a great way to teach other surgeons in their training how to repair the mitral valve, because when these procedures are done the traditional way through the breastbone, sometimes it's hard for even the surgeon to see, and it's definitely hard for more than one person to see. But when I do these with the robotic system, it's up on a 60-inch flat screen TV, and everyone in the room can see exactly what we're doing. So it really gives a better level of understanding of the mechanism of the problem and how to repair it.
Well, I know so many great graduates who come out of this school. I know we take in 165 or 167 students every year. Many of them come in for certain specializations, but now that you're here, I think some of them might switch their major and come over to do some of the valve replacement that you're doing, because it's so valuably important in preventing further heart disease.
Absolutely. We've got a teaching console with the robot so that they can watch and in a graded manner participate more as they learn more about how to do it. And I've told them, I mean, the technique that I use to repair these valves is very teachable, and I promise them all they're going to leave here as accomplished mitral valve surgeons.
Because there are students who come from all over the state to learn medicine here at MUSC, and to have someone with your skill, knowledge, and ability, particularly one of the first robotics ever, you've had your hands on them, you've been doing it, you've been repairing people with a great high level of success. You've sent people out back in 99%? Wow, that's a good number.
So one of the great things I've really appreciated since I've been at MUSC is that we have the South Carolina Heart Valve Center here. It was started by Dr. Danny Steinberg, who's a structural cardiologist. And he and I have been working together really closely since I've been here. The nice thing is that we have a whole breadth of treatment options to offer patients, from standard medical therapy as an initial thing. We can replace some valves now with a catheter, literally through a needle stick in the groin, catheter, a new valve that's on a balloon or in a sheath, pass it up, and replace an aortic valve that way. Wow. Some people...
This has never happened in South Carolina before. This is brand new.
Well, this has been going on for the last few years.
But at that level?
At that level. It's been a couple of years now that we've been doing that, so we can replace those valves. There are some people who are not candidates for surgery who we can repair their mitral valve with a clip that goes in through a needle stick. Not as good as I can do it surgically, but if they're not a candidate because of other issues, we can take care of it that way. We can do robotic repairs, which are less invasive, and then we can do standard open heart surgery. So every step along the way, from the most invasive to the least invasive ways, we have options for people, and we try to tailor the treatment to that patient's individual problems. Dr. Steinberg and I have a clinic that we run together. So you have a cardiologist and a cardiac surgeon who are there at the same time. So patients who are traveling from out of the area, they don't have to keep coming back and forth. They can come here once, see both of us, get the testing done, and leave with a plan that's tailored to them, with he and I talking together and saying, okay, here's this person, here's their problem, what's the best thing we can do to get them feeling better quicker?
And just briefly to talk about Orangeburg, where we're based, it's been my doctors, my cardiologists in Orangeburg who've recommended, other procedures that I may need for my heart, and they send me to Charleston. They send me right here to MUSC, because what you guys are doing is on a cutting edge and also a little more advanced in that area. So it's all a team. I mean, if you can't do it, you got to send it to somebody who can get it done.
Absolutely, and it is a great team here, and we really work collaboratively. And the patient and the patient's family are part of the team as well, and everyone makes the decisions together. I enjoyed speaking with you. Thanks.
Again, ladies and gentlemen, Harvey Elwood, we're here at MUSC. We're talking about valve replacement or repairing valves, and Dr. Mark Katz from MUSC.